Amazing. Okay, good morning. Welcome to our webinar today on understanding smell loss in Parkinson's disease. My name is Kat Kershaw. I am a education and support services coordinator here at Parkinson's Society BC. And I have the honor today of facilitating this webinar with Dr. Patel. Just before we get started, just some housekeeping. If everyone could keep themselves on mute. We will allow the use of the chat function. So any questions, feel free to pop those through the chat and we'll go towards those at the end. Dr. Patel is going to speak for maybe 45 to 50 minutes and then we'll leave 10 minutes at the end for questions. Again, if you don't feel comfortable unmuting, feel free to pop those questions in the chat and we'll make sure that we come back to them. And we won't be sharing slides at the end of this session. So we've got the recording and we'll send that out afterwards. So without further ado, I would love to introduce Dr. Patel. So Dr. Patel is a professor in otolaryngology, head and neck surgery at Stanford University, where she also serves as director of endoscopic skull-based surgery and the Stanford Initiative to Cure Smell and Taste Loss. A leading expert in olfactory disorders and sinus disease, Dr. Patel is internationally recognized for her research on smell loss and its link to neurological conditions like Parkinson's and Alzheimer's. She is actively developing innovative treatments aimed at restoring smell loss and improving patient outcomes, and we're very honored to have her here today.
Thank you so much, Kat, for that really nice introduction. And I'm really happy to be here. Hello to everybody that's attending. I'm going to go ahead and share my screen now and bring that up for you. All right. Is that looking good to you guys over there? Okay, great. So, as Kat mentioned, I have been studying smell loss for a long time. And I'll use the words olfactory loss or olfaction interchangeably with smell loss. That's just a sort of more technical term for that same thing. And I hope, those of you that are out there with Parkinson's, or if you're a family member or friend of someone with Parkinson's, that you get a lot from this. And I'm happy to chat and take questions at the end. So these are my disclosures. One is relevant to something that I'll speak at the very end. The Olfera Therapeutics is a company I've co-founded, and we'll briefly touch on that. But just to make sure that I'm totally transparent about all my disclosures, none of the others are really relevant to this talk. So, I think a lot of people out in the lay public really became aware of smell loss because of the pandemic, because, smell loss with COVID-19 became so prevalent, and more people understood then how impactful loss of smell and taste is to someone's quality of life. And, I'll just run this little video for you. This is a tumor, a skull-based tumor. As Kat mentioned, I'm also director of endoscopic skull-based surgery. And so, a lot of my time and a lot of my training went into, taking out tumors like this. I'm not going to show you the gory details because I know not everyone wants to see that, but I'll just go straight to the end here and show you that you can take out almost everything out of someone's nose. And unfortunately, then those people also can't smell and taste. And we're learning more and more about how neurodegenerative diseases like Parkinson's and Alzheimer's have smell loss associated with them. And I'll go into a lot of detail. But, those of you that already have smell loss, or those of you that know someone with smell loss, you already know that, your ability to smell and taste your food across cultures and geographic regions of the world, across societies, that's really the way in which we gather as human beings over food and drink. And so not being able to participate in that anymore, and also not being able to protect yourself when there is fire or something has gone bad and you don't know whether or not you should eat it, those are really impactful on your quality of life. And when you ask people who have lost their smell, whether it's from Parkinson's or any other reason, there's hundreds of different reasons why, unfortunately, people end up like this. There's a lot of different things that people will talk about: fear for personal safety, anxiety about personal hygiene and how people smell. You know, I have lots of patients coming into my clinic dousing themselves in cologne because they're worried that they can't smell their own body odor and they're worried other people will smell that. And then, of course, this social withdrawal that happens when you're not able to participate in that gathering over food and drink that can lead to depression. And most importantly, you know, you can see that mortality in anosmics. And anosmic is a word that basically just means someone that cannot smell, is almost 4 times as likely than in people with normal smell. And a lot of that probably has to do with the links to neurodegenerative disease. I'll go just briefly into these other ways in which smell impacts our day-to-day lives and quality of lives and how we interact with other human beings. I could give a whole hour-long talk on this, but this is a really funny study to look at. You can see that there's a bunch of women smelling a bunch of men's underarms and armpits, and this study really showed for the first time, and now there have been many more sort of technical and advanced studies showing the same thing, that the way that we actually pick our romantic partners, our sexual partners, and our lifelong partners is actually based on our smell. And this is a very complex picture. I know you won't, not, probably most people on this call will not understand what this means, but this is a part of your immune system that our noses can sense. This is on a subconscious level, not on a conscious level. But this is actually the mechanism by which you have picked your partners, your sexual partners, and lifelong partners. And women are more likely to choose uh, male partners that have as different an MHC class from their own as possible. And that trumps all the other things you think about how you chose your partners, how they look, how successful they are, how compatible you may be. This is actually the thing that determines it over all of those other things. And then this is just one other thing that's really interesting. Maternal infant bonding is very mediated by smell. You can see a really interesting study from the 80s that showed that if you presented nappies to mothers of lots of different babies, they were able to pick out the nappy from their own baby, and they had a preference for that nappy, unless the mothers were suffering from postpartum depression, in which case they lost the ability to prefer any or even choose their own baby's nappy out of all the others in the group. And so these are just a couple examples just to show you how even on a subconscious level, smell is so an integral part of how we interact with each other as human beings. And we may not even know how it's impacting us as we lose it in that way. Here is a really interesting diagram to me. And you can see that these are the number of olfactory receptor genes that we have, meaning the number of olfactory receptor neurons that each of these animals have in our noses to pick up on different smells, different odors. And you can see that humans are kind of down low at the bottom compared to all of these other animals. And up at the top is the African elephant. And you might start thinking at the beginning when you start thinking about this, you know, well, maybe that's just because of how big elephant noses are. But there's something else we know about elephants that sort of makes them stand out in all the other animal kingdom, and that's their memory. Elephants have a better memory than almost any other animal that we have studied in that area. And that brings us back to neurodegeneration, which we're talking about today. Back in the 80s, National Geographic sent out this smell survey to all the people that were subscribers. And they established back then this prevalence of smell disorders, at least in the United States. And you can see that a quarter of the population over 53 at that time, and it has really only grown, suffered from some amount of smell loss. You can see that there was a 10 million people in the United States with total loss of smell before the pandemic, and you can add about 15 million more since. And why is it that it's age related that people cannot smell? Well, there used to be this big category of patients that we called idiopathic smell loss. Idiopathic meaning we don't know why. But we actually now know a little bit more about that. We've studied in this, patient cohort of people that present with loss of smell and taste, and we don't know why. We can't point to a particular virus that caused the loss, or an inflammation or infection or a trauma, or one of the other metabolic or endocrinologic disease states that we know can cause smell loss. When you look at those patients when we don't know why it is, and we look specifically at Parkinson's, you can see almost a third of the patients that initially presented with we don't know why smell and taste loss eventually develop a Parkinson's disease diagnosis. So that is a really large percentage of the people that we're seeing where we don't know what's going on. And the even more interesting thing about this is that the average time from presenting with loss of smell and taste to the diagnosis of Parkinson's on average was 10 years. So you can start thinking about how, if we had a really precise way of measuring smell, which we don't currently, but we're working on it, if we had that, could we potentially diagnose people 10 years prior to when they're currently being diagnosed, get ahead of these disease states, figure out a way to prevent everything that happens after? This is just a brief directing you to a statement. This is a 600-page document that I led and had over 50 co-authors from around the world working with me on in 2022 when we published it. And there's not enough time in this webinar, but if anyone has interest, this is open access. And so this was, as of 2022, all of the clinical knowledge we have about smell loss, the different etiologies that can lead to it, and up until 3 years ago, the treatment options. So if you would like to delve into that more on your own, feel free. I will just briefly go through the mechanisms of smell and then how that means smell loss can happen. So when we breathe in an odorant, we have 6 to 10 million olfactory neurons, these nerve cells on either side of our nose, all the way up at the very top, deepest part of our nose, that pick up on these odors. Those nerves are called the olfactory receptor cells, and they send that signal up to this organ called the olfactory bulb. And you can see that's what's sitting right above that little thin plate of bone that separates the sinus and nasal cavity from the brain cavity above. That's what we call the skull base. And as it goes through that cribriform plate portion of the skull base and connects in the olfactory bulb, it should be connecting in a very specific way. Only in a couple of different spots can neurons that are picking up on a particular odor go and connect. And then that neuron should send another signal back to these really important areas of the olfactory cortex. You can see there's the piriform cortex, there's the uncus, there's the medial olfactory stria, and all of these are integrally related to the areas of memory. And when we think about how memory and motor function and all the other things that come about with Parkinson's or Alzheimer's or other neurodegenerative diseases, it is these interactions where we see dysfunction. And I'll just briefly touch on that. Those of you living with this condition probably have done a lot of research or heard a lot about why does Parkinson's disease happen. And I'm, again, don't have enough time to go through all of the different theories as to why Parkinson's might occur. But I would say one of the leading theories is this complex interplay between our underlying genetics and environmental factors. And when you think about how inflammation and immune dysfunction occurs within the brain, and the environmental factors that can cause that to happen, the leading areas where that may be sort of able to access or trigger changes in the brain. There's a lot of interesting research going on in the gut-brain axis when we eat things, how the things that we take into our gut may affect the immune system and how that might affect the brain. But where there's a lot less research, but a lot more obvious connection, is actually through the olfactory system itself. The olfactory nerves are the only nerves that are externally exposed to the environment that directly then access the brain. And so if we start thinking about the olfactory system not only as a signal of what's going on in the brain, but actually as a conduit for potential environmental interaction with the brain, we start to maybe understand a little bit more about why smell loss may be happening 10 years prior to any of those other symptoms that we're seeing in Parkinson's disease. This is a picture of my grandmother who has since passed. She didn't have Parkinson's, but she had Alzheimer's disease. And she was such a sweet and generous woman throughout her lifetime until the end. At the very end, she had completely changed. Her personality had changed. She was not aware of who was around her at the end. And I bring that up because it's not just Parkinson's. If you look in this slide that I just showed you, you'll look at this little area of the brain and you can see what are called the BRAC stages. BRAC stages 1 and 2, 3 and 4, 5 and 6, and that Lewy body pathology burden that we know is so common in Parkinson's disease. And you can see BRAC stages 1 and 2 are where we see olfactory and autonomic disturbances. Well, if you also look at Alzheimer's disease, that also uses BRAC staging. And you can look at neurofibrillary changes, and that is associated with the amyloid beta plaques that are known in Alzheimer's. So there are a lot of different neurodegenerative diseases. These are just two that I've mentioned that actually show the reason that we have these BRAC stages are actually post-mortem analysis, autopsy of brains of patients that have suffered from these disease states and died. And that is how we know where these earliest signs of neurodegeneration begin in multiple neurodegenerative disease states. And it's in the olfactory bulb and in the olfactory cortex that these changes begin. Not only that, but when we look at neurodegenerative diseases like Parkinson's, and we look at the normal smell, sort of testing that we do, many of you may be familiar with dopamine transporter binding, imaging findings that we use to sort of diagnose and predict change from mild cognitive impairment to the actual disease state. If you add a smell test to that, that increases the ability to predict. 67% of patients with mild cognitive impairment will develop post-Parkinson's within 4 years if they have those other changes plus a smell test. Not only that, but you can take it one step further back. In the largest longitudinal study on aging that we currently have in the US, that's the NIA-led Baltimore study. For each point lower on a smell test that healthy aging adults score, they have a 22% higher chance of developing mild cognitive impairment. This is a very, very early sign, regardless of which neurodegenerative disease state people eventually develop. And then this is the latest study that maybe a lot of you have recently heard about because it was really exciting and being able to identify a biomarker, this alpha-synuclein seed amplification study that was published in The Lancet. And what that is actually testing from the cerebrospinal fluid that surrounds the brain and spinal cord, this specific biomarker. But what was most interesting to me about this study is how that really interacted with smell testing. So you can see when you look at the overall, all Parkinson's disease cases, right above where this little arrow is, 87.7% sensitivity of this biomarker. So really good. But if you add smell loss, hyposmic patients, if you add that one clinical sign to this biomarker, that sensitivity shoots up to 97%, a huge increase in sensitivity of being able to pick up on who truly has Parkinson's. If you go a little further down this, this little table here, and you look at, okay, well, when we look at genetic, mutations and how well that predicts it, you can see the GBA mutation actually has a pretty good sensitivity with this alpha-synuclein seed amplification array. But the LRRK2 is a little less. You can see that that one goes down to 67.5 as opposed to the 95.9 of the GBA. But if you go further down the table And again, just for that LRRK2 mutation, if you add smell loss as a clinical sign, then that again bumps it up. So taking these biomarkers that we're starting to learn more about and adding a smell test seems to increase our sensitivity and specificity a huge amount. Now, I'm going to now sort of transition into, well, if you have smell loss and Parkinson's, what are the different things you can do to try to treat it? And then we'll get back at the end to, like what might be there in the future relating smell loss specifically with Parkinson's and neurodegenerative disease states. But I did want to sort of let you guys know that there are things that you can try to help when someone has smell loss. And the more we study this, the more we realize that perhaps potentially these treatments may affect the structures that are actually intracranial and not just within the nasal cavity. And so how that interacts with the entire disease state is yet to be known, but may actually interact with the entire disease state. So olfactory training is maybe hopefully something that many of you are familiar with. It's the most widely known and understood treatment option now for patients with smell loss, regardless of the etiology. And this has been studied in patients with neurodegenerative disease. Really, all that is a structured smelling protocol. So, if you had a stroke and you lost function of your arm, you'd go to physical therapy and work that arm to get the function back. That's exactly what olfactory training is for your sense of smell. We start with these 4 different odors. The reason we start with these particular 4 is that they're in different categories of smell. And so hopefully we'll stimulate different types of olfactory receptor neurons to wake back up and regenerate. And what we're utilizing is the olfactory system's inherent regenerative capacity. And that is actually unique in all of the other cranial nerves. None of your other cranial nerves have the ability to regenerate. But these olfactory receptor cells that I showed you, they do. They're doing that, and they have been doing that throughout your lifetime. Every 3 to 4 months, one neuron dies off and should be repopulated by a new one. Now, certainly, when neurodegeneration sets in, that whole functionality may go awry. But olfactory training can work to help stimulate the basal stem cells that are within the olfactory lining to produce new neurons. This has been shown through basic science studies that olfactory training actually stimulates that production of new neurons. This is what convinced me that we're really doing something significant. This is a functional MRI study where they took patients with loss of smell and presented a smell to them in a functional MRI. And the areas of the brain that lit up in that imaging study were kind of disparate and chaotic, and nothing really made sense. But after olfactory training for several weeks, if you put that same patient in the functional MRI and you presented that same odor to them, just the entorhinal cortex, the olfactory cortex, where it's supposed to light up right away, lit up. So we're really changing synaptic connection by doing this structured smelling protocol. This is just one of many randomized controlled trials that have shown that they can help. This was a group of patients that were post-viral and idiopathic. And I already talked to you guys about how maybe a significant percentage of our idiopathic patients actually end up having neurodegenerative disease later on. And you can see that when you do olfactory training, you really can improve what we call the minimal clinically important difference, like what patients can actually notice as far as what they can smell or taste in the smell testing. And what we used was this identification test. It's a very common test used in the United States. It's just a scratch and sniff booklet. You can see that age does correlate. So unfortunately, the older you are, the harder it is for this to help. And the duration of loss before intervention was also something that correlated. Something that a lot of patients with smell loss are put on by either their primary general kind of practitioner doctors or general ENT type doctors is steroids. And I wanted to know, is this something that actually helps people? And the short answer is that there's some weak evidence that systemic steroids might help, but no good randomized controlled trial evidence. We know that topical steroid sprays do not help patients with smell loss, but topical steroid rinses may help patients with smell loss. Now, um, in a Parkinson's disease population, we haven't studied that specific etiology with this intervention, and so this would be an extrapolation. But as I mentioned earlier, when you think about how environmental factors that enter our body through the upper respiratory tract, our nose, interact with the olfactory system and cause inflammation in that area in and around the nerves, it may be something that could be helpful, not just in preventing smell loss, but actually preventing inflammation in and around that area that is connected to your brain. So I think that this is something that is ripe for an area of research. I'm only one person, so I only have so much time to do all of these studies, but that is an area that I am hoping to study soon. Whether or not this type of intervention may be helpful in the trajectory of neurodegenerative disease states. Omega-3, high-dose omega-3 is another intervention that we've studied. This I specifically studied in a post-endoscopic skull base surgery patient population, like that video I showed you at the very beginning, where we have these tumors that take up the nose and sinus area. And even when those tumors are not involving the olfactory system, probably that post-operative inflammatory state is why a significant number of patients remain having smell issues after that type of surgery. So many different etiologies of smell loss have this repeating theme, this end state of inflammation in and around the olfactory nerves. And so that's again why I tell you about all these different interventions that may or may not help patients with Parkinson's and smell loss, but are very simple to try and have very low downside or side effect. When we studied this omega-3 in this patient population, there was a precipitous drop in the number of patients that had long-term smell issues after the surgery. So going from, again, almost a quarter of patients having issues 6 months after surgery to less than 5% of those patients having long-term smell issues. So a significant change in the ability of the olfactory system to bounce back and regenerate came about by this high-dose omega-3 treatment. And that makes sense because omega-3 is really just one of the building blocks of the nerve sheath of these peripheral olfactory receptor neurons. The latest thing that we have been studying is PRP. What that stands for is platelet-rich plasma. It's basically taking blood from the patient themselves and putting it in a centrifuge and spinning it so that it separates out into different components. And what you get is a high concentration of platelets along with the growth factors and anti-inflammatory factors that platelets produce, and a low concentration of red cells and white cells, which are the inflammatory cells that circulate in our blood system. And, you know, a lot of people are familiar with the clotting function of platelets, but not as familiar with this anti-inflammatory and growth factor component of what they do for our bodies. I initially ran this pilot study in olfactory dysfunction way prior to the pandemic. And there were, again, some idiopathic patients that were in this group and some post-viral patients. And I really just wanted to prove that it was safe, that it was feasible for me to inject platelet-rich plasma directly back into the nasal cavity up high and deep where that olfactory epithelium is. And I did show that it was. And I saw an interesting enough change in patients' threshold at being able to pick up on odors in this very small number of patients that I decided, okay, this is worthwhile studying in a randomized controlled trial fashion to really see, does it have true efficacy? Then the pandemic hit. And so, of course, the vast majority of patients with smell loss we were seeing then were COVID-19 related smell patients. So this was very specifically studied in that group of patients when I did my trial. In this group of patients, when we randomized patients to either getting a PRP injection in the nose versus a sham injection with saline, just salt water, the PRP group had a greater than 12 times odds of having smell return and improve. I followed this study up with a long-term study. So after I knew that it was helping patients, at least in the short term, I wanted to know, well, is that effect sustained, or did they just get better and then go back down to where they were before? So I decided to follow up on these patients 1 year after their injections. And you can see again, we just use this identification test. And you can see that not only were the benefits sustained, but they actually continued to improve. The trajectory continued to go even further up compared to the low sort of spontaneous resolution that we know can happen over many months and years. And again, this was in a post-viral group of patients, so not studied in Parkinson's disease, but I will tell you that I have now opened up this treatment option as a treatment for any etiology of smell loss, any reason why people end up developing their smell loss. And not only is that, significant in these post-viral patients, but we've seen improvement in post-traumatic patients, and our group of what we, term idiopathic, or we don't know why. And, eventually, it'll take many years, we'll be able to see whether or not PRP is actually significantly helping patients who eventually get diagnosed with neurodegenerative disease, because of course, we probably some significant portion of that idiopathic group is going to end up with that diagnosis. This is something that I tell you about today just because of, again, these theories of what may cause Parkinson's to occur in the brain. And viruses, our exposure to viruses and toxins in the air, but viruses throughout our lifetime, and the inflammation that occurs every time that we have some sort of viral event occur in our nose, is one of the theories as to why there's inflammation or immune cell activation in the olfactory system and olfactory cortex at the onset of Parkinson's. And so I tell you about this because what I became interested in when we were going through this whole pandemic was, there's a lot of our study was focused on how do we treat COVID-19 smell loss. But what I started thinking was, how can we prevent COVID-19 long-term smell loss? And this, in my mind, fits very well along when I start thinking about how could we prevent post-viral inflammation that may eventually lead to neurodegenerative diseases. So, during the pandemic, what we knew about what caused these long COVID type of symptoms, including long-term smell and taste loss, was the fact that we learned that there were viral reservoirs, that even after your body clears the initial infection, that little pieces of this viral RNA stayed within these cells in the olfactory mucosa, and of course also in other parts of the body, in the gut, in the lungs, in the cardiovascular system, in the brain. And what we know is that the higher the viral load at the onset, the more likely the sort of viral reservoirs were likely to be later on. And what we also knew was that you could take an antiviral that could potentially decrease that initial viral load. And what I wondered was, could that potentially decrease the formation of these viral reservoirs, at least in the olfactory system, and potentially prevent progression to chronic smell and taste dysfunction in that group? And you can see that what this shows you is that significantly, when we looked at patients who either did receive Paxlovid within a week of their initial viral event or did not receive Paxlovid within that initial week, all of these other sinonasal symptoms that we commonly see with COVID-19, those long-term chronic setting groups did not change, but the smell and taste, that potential for the loss of that smell and taste because of the inflammation around the olfactory nerves, that was significantly different between those two groups. And so this, for me, is significant for potentially thinking about in terms of neurodegenerative disease changes. Now, I'm getting towards, getting back around to, what is the potential future, specifically in Parkinson's disease, but in my mind, for all patients with smell loss. And these may be things that you have heard about for smell loss or smell dysfunction, that I do not offer patients. And if you have questions about that, feel free when we get to our question and answer session to ask me why I don't. But in general, these are not things that I offer. There are lots of potential future therapeutic directions. I am most interested out of all these different things in electrical stimulation. And this goes back to, I look a lot to the neurosurgery and neurology literature to see what has helped other parts of the nervous system as far as nerve regeneration. And so, why would I want to intermittently electrically stimulate nerves? Well, if we think about peripheral nerves, we know that the underlying mechanisms of how nerves function is that there's this increase in what's called cyclic AMP, and this induces a sort of rapid and sustained upregulation of the regeneration associated genes that we find in all nerves. And that leads to the acceleration of these axonal outgrowth across injury sites and reinnervation of end organs where before there was degeneration and not innervation of end organs. You all, of course, are very likely very familiar with deep brain stimulation. This is something that has helped a lot of patients with Parkinson's because of its ability to modulate nerve signaling, right? So, specifically for motor symptoms for a lot of patients with Parkinson's disease, deep brain stimulation has been really helpful in being able to modulate those types of nerve circuits and either ablate, meaning sort of cut down on that nerve signaling, or just change the nerve signaling to a different type of pathway. So we know that electrical stimulation, both in peripheral nerves and in the central nervous system, can be helpful for correct signaling of nerves. For the olfactory system in particular, what's important is not just reinnervation, but correct innervation. Like I told you, it's a very specific pathway that these nerves have to go to the right place in the olfactory bulb and then go to the exact right place in the cortex to get the correct signal back that our cortex understands as correct smells and tastes and can, stimulate the rest of the brain regions around it appropriately. And what was really interesting to me was this study looking at the femoral nerve because it contains both sensory and motor components. And if you injure these nerves and you do a surgical repair without stimulation, you will get some reinnervation, but it will be random. There will be kind of an even redistribution between motor to the muscle and sensory to the skin. But if you do that same surgical repair with electrical stimulation, you get the exact right target. You get 2/3 that regrow and go to the cutaneous sensory component, and 1/3 that goes to the motor muscle component. So there is something about electrical stimulation of nerves that makes them have the correct signaling pattern. And for so many disease states, including Parkinson's, you know how important that is. So who might benefit? Well, lots of different people, including people with Parkinson's and smell loss. This is a very brief basic science study I did some years back in rats to see just like if I injured the olfactory system and I stimulated the olfactory system within the nose, would that do anything to bring their smell back? And you have to keep in mind that rats and rodents in general regenerate their olfactory nerves very quickly. And so if you study it within the first week or so, you'll be able to see if there's any difference. And that is actually what we saw. We saw that in the rats that were injured and then stimulated with electrical stimulation in the nose. Their ability to find food, which is it's an assay where you bury a food pellet and then the rat has to dig and find their food pellet. That time to be able to find the food was significantly improved in the electrical stimulation group and even improved past their baseline over time because it ends up being a memory activity if you have smell. But if you never actually develop your smell back completely, you can't develop the memory of how to find it. And so you see those rats that were not stimulated never actually even got back to their normal baseline. This is actually what their olfactory epithelium looked like before and after stimulation. You can see a significant improvement and regeneration when they were stimulated versus not. What that also kind of brings me back to is what I started touching on and what I've kind of mentioned a few times is that currently right now, when we're doing smell testing, we're using identification tests. That's the most common one, at least in the US, and other types of sort of subjective tests throughout the world. But we don't have a good objective test of smell right now. The existing methods are asking you, do you know what this smell is? Can you identify this smell? How strong is this smell compared to this other smell? All very subjective. And in that document that I referred you guys to, if you want to read more at the beginning, that 600-page document, this is our 20-page table on all of the existing smell testing methods that are out there around the world. And you guys know when there are this many different options of testing something, what that really means is that we don't have a very good test. We don't have one that has risen above all the rest and that everyone uses. And the reason for that is that all of these are subjective. They're time intensive. When I give someone a smell identification test right now in the US, I don't know, is it because they don't get the answer right because they cannot smell it? Or is it because they've never been exposed to that particular odor before? Is it because they don't speak the language that we're performing the test in? Is it because this patient is not literate and they are too embarrassed to tell me, their physician, that they are illiterate? We know that the vast majority of illiterate patients do not tell their doctors because they are embarrassed to tell them. We also know that the rate of illiteracy in this country is skyrocketing over time. And then, of course, there is the cognitive barrier. If someone doesn't understand what they're being asked to do when they're performing a smell test, are you truly testing their smell or not? So, although I just showed you all of that really interesting data about how smell is linked to and can be predictive of Parkinson's disease, we are probably missing a huge swath of the population or misdiagnosing a significant proportion of patients because we are currently only limited to these very rudimentary subjective smell tests. So that's what I'm working on now. I'm working to develop this endoscopic direct electrical recording device that I can just simply place high and deep within the nose. I'll make it comfortable, of course, for people for me to do that. And I've been doing some self-experimentation to see what's the best way of putting this into my nose. We've been miniaturizing electrical circuits that we can place within there. We have now about 20 individuals around the world that are working on electrical stimulation in some capacity, whether it's my type, that's an episodic endoscopic stimulation, or actually developing olfactory implants that we could place and potentially leave in there to stimulate the system. And then this is the part where, again, I want to be totally transparent. This is a company that I've co-founded and do have equity in. But when you think about, well, the olfactory system may be this conduit for toxins and environmental pollutants and viruses to access the brain, well, why can't we use the olfactory system actually to treat these diseases? As many of you know, one of the reasons why so many promising drugs that go through animal models and animal studies don't end up panning out when we bring them into human trials is because of the fact that if we're taking them in a pill form, we need to metabolize them, absorb them through our gut, our GI system, metabolize them appropriately, and have them be high enough concentration then in our bloodstream that they can then cross the blood-brain barrier and affect our brain, but not be so high concentration that they create a lot of bad side effects and toxicities. Even when you give someone an injection, or you try to, give someone a spray in the nose, all that is currently doing is being absorbed into our very vascular nasal cavity through the mucosa and going directly into our bloodstream. But you still have the blood-brain barrier that's impacting the ability from these drugs to get into the brain itself and impact the disease states like Parkinson's and others. But if we could actually utilize the olfactory nerves, those nerves go right through that blood-brain barrier and go right into the central nervous system, right? And so that is what we're currently working on now to develop a platform that can utilize the olfactory system to deliver drugs for Parkinson's and for other disease states, any central nervous system disease state directly to the brain. We've developed this chip so that we don't actually have to even use animals to study, and you can see how drugs are delivered through multiple steps into the brain. And with that, I'm going to end and take questions for the rest of our time together. And if you want to know about my latest research or what we're currently working on, I post it on my Instagram page. So if you'd like to follow me there, you can. I'll go ahead and stop sharing and happy to take questions.
So we had one come in through the question and answer chat. Linda was just asking regarding the post-viral influence, is there also a post-strep influence? She said here that she'd suffered severe strep 25 years before smell and taste loss, which came 7 years before her Parkinson's diagnosis.
Yeah, so what I would say is that the quality of the data that we have right now is quite poor for all of this, and we just need better studies done on honestly. And it's difficult to run these types of studies because obviously, if you were to truly track people in a longitudinal fashion, a study like that would take 20 to 30 years to complete, right? But we do have some data, and yes, just like viruses may have an impact, bacterial disease states, and all basically anything that enters our body that can create some sort of inflammatory response and trigger genetic changes is a potential sort of etiology or reason for developing Parkinson's and other neurodegenerative disease states. And the reason why that is what we now know about what triggers some genes to turn on or off. So we know that there's some genetic impact or predisposition to Parkinson's and other diseases. There is now a lot more information about things like DNA methylation. So the way that your DNA is read out and which genes are turned on or off when the cells are replicating in your body is impacted by the environment. So we know, for example, that in areas of high pollution, we can track that with something called PM 2.5. It's particulate matter that's a 2.5 micron size. We know that in areas with 2.5 microns in a high concentration, people have very different DNA methylation, very different transcription of genes in their upper and lower respiratory tracts than in people who live in regions with low PM 2.5 concentrations. This leads to different inflammatory disease states like chronic sinusitis and asthma. And as we learn more about how the immune system plays a role in neurodegenerative disease states, I think we'll learn more and more about that. So that's a long answer to potentially that strep infection could be playing a role, but we really don't have great data about that yet.
Okay, perfect. Thank you. Does anyone else have any other questions? I don't see any more in the chat, but if you'd like to ask, feel free to raise your hand and I can allow you to put forward your question to Dr. Patel.
Maybe I can ask a question of everyone attending if they're not asking questions. Do the people attending, are there many patients currently suffering from smell and taste loss? And if so, have they been offered these different treatment options that I talked about?
Two raised hands, so I'll just share. I think it might be Sharon, but I'll allow them to.
Hi, it's not Sharon, it's Alf actually.
Hi,
And I am a 75-year-old man with Parkinson's, diagnosed about 6 years ago. And I have a history of never having remembered being able to smell at all in my lifetime.
Wow.
I was born in 1950, and the polio epidemic happened in early mid 50s, something like that, I think. And I'm told, although I don't know this for sure, that one of my sisters and myself had some positive tests for polio, but never developed symptoms at all. And I'm really curious whether that's the kind of thing that could also have affected the olfactory system to, in my case, just shut it down completely.
Yeah, that's a great question. And I do think that's potentially what happened in your case. You know, there are some patients who have congenital smell loss because they never appropriately develop the olfactory bulb or olfactory like tract
Mhm.
or olfactory nerves in the nose. We can see that on an MRI. We can see in those patients that they just are missing or they have a very tiny hypoplastic olfactory bulb. And we know that there's some genetic conditions and some syndromes that predispose people to that. But then there's this other group of patients who we have grouped into this congenital loss simply because, like in your case, they never could remember having smelled anything, but they seem to have a completely intact olfactory system, developmentally speaking.
Mhm.
And, you know, we know that infants and toddlers, so much of the time, they're exposed to so many new things in their environment and they're not able to tell us what they're experiencing, right? We know when they look sick or if their nose is drippy, and we just, you know, sort of expect and tolerate that in most kids. Like they're just gonna go through their, you know, years of being exposed to things and develop a good immune system, a robust immune response. And there are certain vaccines that can help them with that, have an immune response without having the symptoms that the virus might cause. But yeah, I think that that's definitely a possibility in your case.
Thank you.
Of course.
I just have a question here from Hallie, so I'll just let her.
Can you hear me?
Yes,
Yeah.
perfect. Go ahead.
I'm a person with Parkinson's. I'm 88 years old and I have loss of smell, and I lost my smell about 15 years before I was diagnosed with Parkinson's. Although in the last 2 years I've had days where I've been able to smell. The smell isn't something I can identify. I can't It's not something I've had before or smelled before, but it does come and it goes away again.
Oh, that's so interesting. Uh, and I wonder, are you on treatment for your Parkinson's, or have you had any treatment for the smell before that happened?
I had no treatment for the smell, and I am on levodopa for Parkinson's. I take 5, 25, I take 5 pills a day,
Yeah.
and I'm active. I do Tai Chi and I exercise and I walk, and
That,
that's taste and smell are the things I'm uh, mostly would like to have back.
yeah. Well, I think that, you know, again, as we start to understand more about the underlying mechanisms of why the loss has occurred, we'll start to understand why some people can have some spontaneous sort of reinnervation that may be due to treating the underlying disorder more on a central scale, like levodopa, or it may have to do with your other lifestyle choices, like continuing to do exercise and eating healthy and things like that, that may be able to bring down the overall level of inflammation and immune response that's going on in particular areas. And like I told you, you know, your olfactory system, differently than other parts of your brain, is meant to be able to regenerate. And so if we give it the right environment, in some patients it can. And so I suspect that that might be something that's going on with you.
Thank you very much.
Yeah.
I have a similar query from Wendy. She just asked, does smell loss come and go, or is it more permanent leading up to a Parkinson's diagnosis?
Yeah, it can be quite variable, depending on individuals, but I would say eventually it typically ends up being permanent. I would say this ability for the smell system to regenerate means that it can take an inflammatory insult and it might go down to the point where you're able to notice that significantly, that you're not smelling and tasting. And then slowly, as all those 6 to 10 million neurons are regenerating slowly over time, if they are able to regenerate and if they are in the right environment, um, and all of those life cycles don't occur right at the same time, so it can take many months to years for that whole process to take place, then yes, people can start smelling better again. But then maybe they undergo another inflammatory insult. And we know that people over time lose redundancy within the system, right? So although you have 6 to 10 million neurons on either side, each time you have a little bit of a loss and maybe not as many neurons that can pick up on that particular odor anymore. And so slowly over time, after enough inflammatory insults or enough exposure to things that are causing it to dysfunction, maybe that will eventually lead to that total loss.
And then I have two very similar comments from Linda and Ken. So Linda just said, I have Parkinson's and smell loss, no treatment offered. And Ken similarly said, some smell and taste loss, 73 years old and Parkinson's for 18 years, no test offered or talked about. Would you have any advice or any comments on that?
Yeah, I think that, like I sort of mentioned at the beginning, most most people, including most physicians, really kind of ignored the smell system for a long time. And it was really only with the pandemic that a whole lot of interest has occurred in smell and taste and understanding how important it is for our quality of life, and now how it may be really a signal for what else is going on in the central nervous system. We focus on Parkinson's and Alzheimer's and neurodegenerative disease in general for this particular webinar, but I can tell you that the data shows that there are multiple other central nervous system disease states that show a deficit or dysfunction in smell. Things as simple as depression, migraine, schizophrenia, autism, they all have smell dysfunction as part of their disorders. And smell is really this canary in the coal mine that can really give us a hint as to what's going on. But again, most people, even most physicians, are not really aware of that data simply because they have not, there's not been a lot published on it. There's not been a big focus on it. And in comparison to other senses like your vision or your hearing, people don't depend on it as much in their, just to like go about their day-to-day lives. And so I'm not surprised to hear that, unfortunately. It's what a lot of my patients end up telling me when they get to my smell clinic. Um, and I would just encourage you, to sort of talk with your physicians and let them know what you heard so that they can maybe just look up these papers. I have a website that you can sort of direct your physicians to as a sort of reference site. It's the Stanford Initiative to Cure Smell and Taste Loss. And I have a whole page on treatment options and links to all these studies that I just went through with you guys. And so if they're interested in actually like clicking on those studies and reading through them and understanding what they might, be able to offer you, they can certainly visit that website, and you guys can too.
Amazing. I think I've just found it. So I might just pop that in the chat so everyone has access to it. And just one final comment from Linda. She said, best presentation in 10 years. Thank you.
Thank you so much. That's so kind of you.
It's a very lovely comment to finish on. So it's just turned 12 o'clock, so we'll be respectful of time. But please, if anyone has any more questions, comments, feedback, please don't hesitate to get in touch with me. I will also pop the information email in the chat, and we will send out the recording so that you all have it. And the biggest thank you for everyone for joining us today, and thank you to Dr. Patel for spending your time and sharing such a great presentation. It truly was fantastic.
Thank you so much. It was so wonderful to be here. Good luck, everybody.
Thank you, Dr. Patel. It was wonderful.
And I've just popped the website there that Dr. Patel was talking about to share with your physicians. Okay, thank you so much. Enjoy the rest of your day, everyone.
Bye.
Bye.